Good afternoon. Thank you for being at the 2020 International Web-Based Neurosurgery Congress. I'm pleased to introduce you Dr. Mark Richardson. He's a very well-known epilepsy and functional neurosurgeon. Dr. Richardson is the Director of Functional Neurosurgery at Massachusetts General Hospital, Associate Professor of Neurosurgery at Harvard Medical School, and is a visiting Associate Professor of Brain and Cognitive Sciences at MIT. Today, at the IWBNC, Dr. Richardson is going to share his lecture titled Movement Disorder Surgery, Research and Innovation. Please type your questions in the Q&A section, followed by your affiliations. We will read them after the end of Dr. Richardson's intervention. Welcome, Dr. Richardson, and thank you for being part of this Congress.
Camilo, thank you so much. I appreciate the invitation to present. It's a real privilege to participate. This is a great event, so thank you. As you mentioned, I'm at Massachusetts General now. I'm a functional neurosurgeon and neuroscientist. And before moving to Boston, I was at the University of Pittsburgh for 8 years. And so some of the work I'll show here started there, has been transplanted to MGH. Please do, everyone, send some questions in. And I'm going to do my best to leave some adequate time for comments and discussion. So this is a broad topic, and these are, potential categories that could be covered. I am going to just cover these. We don't do focused ultrasound yet at MGH, and we didn't have it in Pittsburgh, so I have no expertise there. And cell transplantation, I think, is the furthest away, although there was a recent publication from one of my colleagues at MGH about cell transplantation in Parkinson's disease. All right, so let's get started here. So the talk is organized a little bit like this. So within DBS, I think you can essentially, at least in the United States now, think about two different schools almost of DBS. One is awake and one is asleep. And then we'll talk a little bit about the future of DBS, which I think is adaptive DBS, or so-called closed loop DBS, which you might get to through either awake or asleep surgical technique. And then we'll talk about gene therapy. We'll switch gears and talk about the evolution of real-time interventional MRI or intraoperative MRI guided convection enhanced delivery in a current ongoing trial in Parkinson's disease. All right, so in DBS surgery, the goal is to place electrodes in the functional target. This is a depiction of electrodes in the STN, reconstructed with LEAD DBS, which is an open source platform for lead reconstruction. So we have a number of ways that we try to achieve this. This is a photograph of our intraoperative setup now at MGH. Where I've switched to using the ROSA for DBS cases, so essentially have replaced the stereotactic frame with the robot, which I think is more precise and has less chance for human error than the Lexel frame, for instance, or the CRW frame or other frame of choice. And of course, we use microelectrode recording. This is Todd Harrington, our neurology partner for DBS. And of course, this is the traditional way to do DBS. Our adoption of the ROSA technique was based on the work of the French group in Grenoble, who of course led the way with development of this robotic system and published their experience recently, if you're interested in this. And we did our own smaller study, just demonstrating how we registered the robot and other considerations that were undertaken for awake surgery, specifically with ability to do research. So here's a boom microphone for someone in which we're doing a speech production task in the operating room. And this shows that you have plenty of room for microelectrode recording. This is very stable, and patients tolerate this quite well. You can't quite elevate the bed as high as you can for a standard beach chair position, if that's how you're used to doing DBS. But it works pretty well overall. And I would argue that, and I think this is still somewhat controversial, that at least for STN and GPI, that the functional target is the anatomic MRI, that we know the anatomic MRI visible correlate for that. In the STN, that's a dorsolateral STN. And in GPI, it's the ventral posterolateral portion of the GPI. And we know this through now really decades of work of people comparing post-op imaging with pre-op imaging and looking at where the leads ended up in patients that improved. This is one of a few papers that looks at repositioning of electrodes. The point of this paper was that when electrodes were repositioned from small distances into the dorsolateral STN, patients improved. So it's really on the basis of that general concept that this system was developed. This was developed at UCSF while I was in training there. What I'm showing you is the ClearPoint system for interventional or MRI guided placement of DBS electrodes. It can be used for the placement of other types of probes, which we'll get to later. But this is a skull-mounted aiming device. The patient is under general anesthesia, and the entire procedure can be completed in the magnet. And one can convert a standard diagnostic scanner for this purpose, or you can use intraoperative MRI. So in Pittsburgh, we had a diagnostic scanner, and at MGH, we have the MRIS. So this system functions in both 1.5 and the 3T environment. There's software that guides you through the various steps of aiming, fluid-filled stem that's MRI visible, which is directed at the target. There's a predicted error that's shown. One then implants a ceramic stylet. MRI scans obtained, and you check and see if you're at the target or not. If you're not, you have a chance to readjustment. It's almost always within a millimeter of the target, at which point you can place a DBS electrode. And you can image that if you choose, depending on your the strength of your magnet and the hospital protocol. So here's an image in the upper right panel of our situation at Pittsburgh, where we were in the diagnostic scanner, and most of the work was done, outside with planning and verification. All right, so which of these two methods is better, and how do we decide what to do? How does this affect overall philosophy on DBS? And let me just mention that a sleep DBS had been done prior to the advent of ClearPoint, in a number of centers. Marwan Harviz and Steve Gill, for instance, in the UK, doing a sleep DBS prior to the advent of this system. So let's look at the different attributes of each procedure. So awake is a traditional method. Many patients prefer this just because it's the way it's always been done. Some people like the idea of being awake and participating. They like the idea of neurophysiological confirmation. Many of our neurologists still prefer this approach. Allows them to be involved in the lead placement, which is important. They can have a chance to learn the patient's physiology in the operating room with you. So I think there's a lot of value in that. Patient can participate in surgery. There's the opportunity for research, of course. But for a sleep DBS, you have immediate imaging confirmation. You can continue medications through the surgery while the patient's under general anesthesia. So for instance, we'll put in an OG tube and administer the patient's Parkinson's meds throughout the case. And this makes it easier for many patients who really don't want to come off meds the night before, for instance, for their wake microelectrode guided procedure. I think this is ideal for pediatrics, for people with severe dystonia and severe tremor, people who have really high amplitude tremor who are otherwise shaking the stereotactic frame. Even though we like to see the tremor resolve in the operating room, these patients do really well with the sleep DBS. And another thing I should point out, I don't have any slides on this, but at least in the United States now, you might say there are two schools of a sleep DBS. One is real-time image guided and verified, and that's using MRI. And the other uses intraop CT, which gives a immediate, essentially post-op check on lead placement. The MRI uses an idea called prospective stereotaxy, where you're using the MRI software to align a trajectory guide and then implant. So it's a little bit different, and in theory provides a higher accuracy. But the outcome studies from both CT verified and real-time MRI guided are both quite good in terms of outcome. Ooh, I forgot to mention significant anxiety. It's one of the most important ones that brings people to a sleep surgery. So I've had a number of patients who have said, well, I've known I was a candidate for DBS for some time, but just haven't been able to bring myself to think about doing awake surgery. But if it's asleep, no problem. All right, so outcomes are expected to be equivalent. So these are some ways that we might help patients choose. If you're fortunate enough to be in a center that can offer both, I think there are a lot of advantages to that. You can essentially leave it up to the patient. Of course, there are other considerations like operating room time and MRI time. But we really have taken the approach that the outcomes should be equally good regardless of what protocol is used. Okay, and here are just a couple examples of that. We published our experience in Pittsburgh in the UCSF group, and others have published on this now a few times. All right, so if that's the case, you might also argue, even though I made a couple good points for it, why would you ever do microelectrode guided if we know the functional anatomic target and we can just put leads there? So I thought I would take a minute and just share my overall philosophy on DBS, how we approach this awake and asleep. So the role of microelectrode recording in general. So in my practice, as I mentioned, because the outcomes appear to be equivalent both in our hands and the hands of others, we make this determination on a per patient basis. And I'm very cognizant of explaining my biases in both directions. So I'm interested in having an active and excellent sleep program. We also have ongoing studies in awake patients to study basal ganglia thalamocortical neurophysiology. And so we talk to patients about that, and we just see what scenario suits them the best. So I mentioned this, we perform cases with ROSA just because I think that reduces chances for error optimally. And we used to check every neuron for movement-related activation, and no longer do that because we found we could get just as good results in terms of localizing the 3 simultaneous electrodes with macro stimulation through the ring. So we use the alpha omega electrodes that have a ring electrode 3 millimeters above the microelectrode tip. So after we've mapped the top and bottom of the STN, we'll deliver stimulation through the macro contact to try to define boundaries with symptom production or therapeutic benefit or lack thereof, and then choose the trajectory for the DBS lead. I wasn't trained to do the VIM cases with MER, so I don't do that. There was a period where I did, and we couldn't determine clinically that it was made any improvement in outcome for the patient, so we stopped doing it again, went back to just testing with the lead. All right, so here's this question, why continue to do microelectrode-based cases? So if you accept the premise that the outcomes are, at least as best we can measure them now, essentially the same between the two methods, the outcomes still aren't perfect. And so I think if we're going to improve the effects of DBS on patients, we need to have a better understanding of network physiology. And so there are a number of open questions related to the physiology that we can ask in the operating room with IRB approved studies. And then we have to think about the relationship of the implementation of closed loop DBS. And we'll talk about this in a minute, but we're really in the era of closed loop DBS now. And whether or not we need to measure the physiologic signal in the operating room, how important that's going to be, how important it might be for placement of a cortical sensor, for instance, if that were to ever be valuable, is an important consideration. So I think in combination with the fact that some patients just prefer, some patients we might prefer, the neurologist might prefer to be there and do the case awake, that this still makes a lot of sense. And in my lab, our overall research goals really combine things that we think have a chance to improve outcome and basic neuroscience questions. We'll talk about that a little bit, but our basic sciences really focus on understanding basal ganglia thalamocortical loop physiology and doing that in as rigorous a way as possible with the short time we have in the operating room. I will say that in general, our field has a problem with outcomes measurement, and that's really hard to do. One reason is we don't have a generally accepted way to localize leads between groups. And I mentioned the Lead DBS platform, which I think is a great platform for doing this. A lot of a variety of studies now coming out in group space showing the relationship even between different centers, implantation sites, and how that relates to outcome. But there's still some caveats to looking at all the data in group space and really understanding what that means for the patient's own individual anatomy. We have a particular interest in voice and speech outcomes, which I think is an under-recognized problem in Parkinson's disease in general. And I won't talk about this in any of the slides, but we are paying attention to the field of neuroethics and want to participate and have a strategy, or let's say developing a strategy with neuroethical consultation for how to engage patients in a way that allows them to participate, potentially get something out of the experience of participating in invasive human neuroscience that is valuable to them, and then it helps kind of go beyond just the treatment of their disease, even though they don't stand to benefit personally from the basic science research that we do. All right, so let's move on then and talk about adaptive DBS. So this is really where the field is heading, starting in Parkinson's disease to a certain extent, but I think has broad applications across movement disorders. And this field has really started with the sensing of local field potentials in the basal ganglia. And I'm not going to do a deep history of this, but I just mentioned that there are a number of different oscillatory features that have been correlated with obviously both normal physiological, but also pathophysiological states. The best known is probably hypersynchrony and the beta oscillatory range in Parkinson's disease. This is has been best associated with bradykinesia, but a number of other symptoms have also been related to different types of oscillatory activity, including dystonia and dyskinesia. Not surprisingly, tremor is associated with a tremor type frequency of fluctuation in signal. So these, I thought I would mention, are the two kind of initial approaches that have been taken to adaptive DBS or closed loop DBS for Parkinson's disease. And so if you're interested in this, here are two good studies to start with, and you can go from there. The group at Oxford, and Simon Little did a lot of this work in Peter Brown's group, have used a single threshold method where if beta power goes above a certain threshold, stimulation is activated. So here's a peak in beta power and stimulation is higher. When the peak comes down, stimulation goes off, comes back on, etc. This is a different approach where the threshold is a dual threshold. So the idea is if the beta power is dropped below a certain level, that the device would actually decrease its amplitude to save power and potentially prevent someone from becoming dyskinetic, for instance, if they're in a very on state in terms of their medication. So it's to be determined which of these might work better, and it could be that a simple single threshold approach is better in some patients, dual threshold is better in others. But this is an area of active investigation. So we do know from studies in non-human primates and now from studies in humans that Parkinson's disease isn't just a disease that's manifest in the basal ganglia, it has widespread network effects. And this isn't surprising because we know that the basal ganglia sits in a circuit with the thalamus and cortex, and that these circuits are segregated. So here's the motor circuit where primary motor areas are projecting and transferring information through the circuit in a way that's topographically organized. Likewise, here's an associative and then limbic type pathway. So these aren't completely segregated. There's some overlap, but for the most part, this is why we can put an electrode in the motor part of the SDN and primarily affect motor symptoms. So some of the most important, relatively recent information describing how Parkinson's disease manifests electrophysiologically in the cortex, and also how DBS might work at a system level has been demonstrated by this technique that has been used most by the UCSF group and Phil Starr's work, where they implant temporarily these ECOG strip electrodes through a burr hole during DBS surgery, and can record simultaneously from both subcortical and cortical structures, as well as recording from the cortex during stimulation. So this group first showed that there was excessive amount of phase amplitude coupling between two different frequency ranges in the cortex, and subsequently went on to show in this paper that DBS, when it reduced symptoms, also reduced this excessive phase amplitude coupling at the level of the cortex. And so this is very important work on a number of levels, can open the field up for the use of this technique, but also showed how a physiological biomarker could be modified with DBS, and provided a good fundamental example for how we might use cortical biomarkers, other types of biomarkers, and measure their response to DBS in different situations for different movement disorders. Here's another publication from the UCSF group. So here's an illustration of how this works chronically when it's attached to, for instance, Medtronic's Activa PC+S device. And this is a first report of chronic adaptive DBS, in this case, targeted towards dyskinesia. So what this figure shows is a band of elevated power and gamma frequency, which is thought to correlate with the patient's dyskinesia. So there's a classifier set up in the software that runs this that determines whether or not this frequency is present, and when it detects it, simulation is is modified, and when the signal goes away, DBS can go back to normal. So this is one of the first examples. There's just 2 patients, but more work coming in this area. All right, so I thought I'd just take a second here to make this point that human neuroscience studies may inform additional applications, and let you know a little bit about the work that we're doing in our group. So I mentioned that we're interested in speech as it relates to Parkinson's disease and outcomes from deep brain stimulation. And this is really an under-recognized problem, I think, in terms of the progressive loss of communication and different types of movement disorders. So this is our setup in the operating room, where we borrow this technique that we learned from Dr. Starr, where we can pass. In our case, we use a high-density ECOG electrode, has 63 contacts, and we put up to 2 of these in. We target the STG, primary motor cortex, primary sensory cortex. Both are kind of traversed on the way to the STG, which is essentially a ventral sensory motor cortex, a vocal cortex. And we're simultaneously recording local field potentials and microelectrode recording single units from the STN, for instance, or the GPI. We can play acoustic stimuli to the patients with instructions to speak, and they can speak, or they can read a written stimulus. So we're interested in understanding the neurobiology of speech in terms of the role of basal ganglia and thalamus, and then thinking about how we might use signals derived from DBS in these areas to potentially modulate DBS differently when someone, for instance, intends to speak. Interestingly, in this work from Oxford and their adaptive DBS experiments in the acute setting, there were less speech side effects, and it wasn't exactly clear why that was. Just another example of a technique that we use where we can do real-time mapping of gamma activation while the patient's speaking in the operating room to check whether we've put the strip electrode in the correct place. And of course, we're interested in getting good research data at this point, but you might imagine in the future, whether you're targeting motor cortex or some other part of cortex that could be activated with a behavioral task, that you might want to have the patient awake and participating to verify that your cortical sensor was put in the right place if we are eventually using cortical sensors in our closed loop DBS. So it's also the type of a thing that we think about in our work. And I just mentioned we published a couple papers now, collect a lot of data with these techniques, and really working on trying to do a rigorous job with the analysis. So clearly basal ganglia is involved in speech production. There's no surprise there. And we're trying to ascertain really whether the role of the STN, for instance, is the same thing in any other motor behavior, or if there might be something different about its participation in speech, or whether speech can help us understand, maybe better than other tasks, what the general role of the STN is in basal ganglia thalamocortical function. Okay, I wanted to show you this just because I think it's interesting. If you have any question about, you know, how important is this kind of sensing cortical business closed loop, there are a number of studies now that have been funded through the Brain Initiative. I'm just clicking through them now, and Parkinson's disease, epilepsy, OCD, neuropathic pain, now depression, that have been funded by the US Brain Initiative, which in the United States has been a real boon to research done by functional neurosurgeons, because it has provided a funding mechanism that is specific to recording and stimulating in the human brain, which has been really important for advancing projects that otherwise might have been hard to fund because it wasn't a traditional focus necessarily of the NIH. Other example of studies involving closed loop systems. So in total so far, it's actually probably higher than this number now, but greater than $60 million spent through NIH, and that excludes the DARPA funding in the United States, which is aimed really at a number of things related to closed loop DBS. So this is a schematic of how closed loop DBS might evolve. Here's where we are now, where we're sensing off the lead. And with the launch of Medtronic sensing enabled DBS in Europe, the Percept device, neurologist, or if you're a neurosurgeon who does the programming, you can look at the local field potentials that are recorded on the device. You can think about that. You can make a manual adjustment of the DBS, a manual medication adjustment. But now for the first time, you can look at the patient's brain physiology in order to impact how DBS programming is done. So this is a really important milestone in the field. We'll move to the stage of adaptive DBS where the device, the onboard computing is making decisions of its own based on the recorded signal. So at first it'd be simple but automated adjustment of DBS settings. One still has to make all the other adjustments in medication, for instance. And it's nice to think that we might eventually reach this situation where we've developed intelligent adaptive DBS where the system can learn on its own, and it also potentially has the ability to make recommendations about setting adjustments to make, and even potentially medication adjustment suggestions based on using data across patients and maybe across time in the same patient. So Julia Newman, who's a collaborator of ours at Charité, has written a nice review paper on this you can check out if you're interested. And I'll just mention that I really think the evolution of this field is going to be informed by learning across diseases. So obviously not just Parkinson's disease, but not just movement disorders. There's a lot to learn from the application of closed loop DBS, obviously in epilepsy. The University of Florida group is doing great work in essential tremor and motor tics. So before we move to gene therapy, I think there's a lot of potential for closed loop DBS, and ideally you might think about it this way, where we might realize our potential to deliver truly personalized medicine, the goal of which is to outperform what medication can do. Not what medication can do at its best, but really outperform what medication can do, maybe still in conjunction with medication. But I think that's really what the hope should be for closed loop DBS, so we can really make it personalized. But in order to do this, we have to keep increasing our understanding of the neurophysiology of disease states, of course, the normal brain physiology, and also what the neurophysiological responses are to stimulation itself. So a lot of work to be done in this field. All right, let's switch gears to biologics and talk about gene therapy. So if adaptive DBS is kind of the stage that the field has entered now, on the biologic side, it's really gene therapy. So there's a lot of interest in cell transplantation in the 80s, early 90s. But really the vast majority of work that's been done in the field is in gene therapy that is moving into clinical trial. And there are a couple ongoing clinical trials. I'm going to talk about one that that went through a phase 1 period in the mid-2000s. This is a picture from infusion at UCSF. Accurate stereotactic targeting, but you can't see what's happening. So the problem with this technique is you don't know where the infusion's going in the brain. So if you fast forward to 10 years using the ClearPoint device, which is the same one that we use for DBS in the MRI, this was actually developed with purpose in mind of doing drug infusion in the brain. And the same company that makes this device also makes a very nice infusion cannula that's MRI compatible and MRI visible without a lot of artifact. And so one does the case in the same way that you would target DBS, but you can see in real time where the infusion's going by mixing the viral vector, which is AAV2, adeno-associated virus serotype 2, essentially one-to-one with gadolinium, or a contrast agent that is like gadolinium. All right, so what that's allowed us to do, and I'll show you some images in a minute, is to really increase the amount of coverage of the target structure. And in Parkinson's disease so far, that has been the putamen. So the idea is to, in the majority of gene therapy approaches so far, to rev up dopamine production in some way. So AADC is aromatic amino acid decarboxylase, rate limiting enzyme in dopamine synthesis. And the idea is that putting this in the putamen, which is the target of afferents from the substantia nigra, where we need dopamine to be made. Patient takes levodopa, it's converted by AADC into putamen. There's a release of dopamine there. All right, so that's how that particular therapeutic works. But delivery has been the issue, because in all of the gene therapy trial studies that have failed, the preclinical data has looked pretty good. This is the average volume of the putamen. It's up here. And these have been the infusion volumes. And look how much lower they are than the total coverage. So this is a very well-known trial, the Neurosurgery trial, which Neurosurgery is an analog of GDNF. And bottom line is just not much of the putamen was covered, maybe 10%. In the first AEDC trial, based on just postoperative T2 imaging, also not much of putamen was covered. This is the first phase of the second phase one for AEDC, which was picked up by an industry sponsor startup called Voyager Therapeutics, who's still sponsoring the trial. And what's been really interesting is the evolution of this technique through the clinical trial, where you can see the volumes have gone up significantly to the point where up to 1,800 microliters are delivered to putamen with a lot of coverage, and a lot of coverage of the post-commissural putamen specifically. And it's really the work of Paul Larson at UCSF, who figured out that it was best not to just deposit a couple boluses of infusate, but to progressively infuse as you go. And that's what's, this is a, whoop, let's go back here. An example of some reflux, an example, and A and B, an example of some leakage outside of the putamen. But you can see that how valuable this information is, because it tells you the cannula has to be advanced, potentially placed in a different spot. It allows you to monitor how much drug is going in, and think about the delivery that was done before we were watching it in real time with MRI. So this is a real game changer for the field of gene therapy, I think, for not only for Parkinson's disease, but really for any application of gene therapy delivery directly to the brain. So what Dr. Larson figured out is if you advance the cannula progressively like this, you get a nice distribution. And then based on the work of Chris Bankovich at UCSF in non-human primates, who's really the person responsible for pushing this technology and this particular idea forward over more than 20 years now. After modeling non-human primates, we started in humans taking a posterior approach, because this approach to putamen would take 2 trajectories per side and would take a long time. And now we go posteriorly through a trans-parieto-occipital approach. And in one shot, we can cover the putamen pretty well. So just a couple minutes before I'm going to pause for questions. So this shows you the targeting on the ClearPoint device, just so you can get a sense of how we do these cases. Here's a putamen. Here's the entry point. You have to be very careful of these sulci in the back, and some of these patients have very thin area right at the back of the insula. Not this particular example, but some of these are very thin. We did these in the diagnostic scanner in Pittsburgh. This is an image there with the patient in the prone position, and the aiming device is mounted posteriorly. Here are the infusion cannulas that are placed. We're getting ready to put the patient in the magnet and start the infusion. And there's the patient in the magnet, and we just continue scanning, continuously scan. So just collect serial scans, waiting for the infusion to appear. So here's a schematic of what that looks like. Actually, let's go back a second here. So this is an image that is acquired right after we've inserted. Here's the device. So there's a step in the cannula which prevents reflux back up the entire cannula. The infusate initially backflows to the first step, and then there's another kind of bulleted step a little higher up that helps to contain the infusion. So the idea is to position that at the back of the putamen, which hopefully you can get a sense of in these images. And here's a schematic of how the infusion progresses. So on the MRI, we might see a little bit of contrast agent that would expand. And once we get a sense that the back of the putamen has been filled, we advance the cannula and we do the same thing, and it grows and we advance it, so forth, until we think we have good coverage of the posterior putamen, and that's the sensory motor part of the putamen, which is really what we want to cover in this particular trial, because the primary outcome measure is motor function. So this is an example of the image sent back into the ClearPoint software, which is one way that we can monitor the infusion. And a few screenshots here of how the infusion has progressed in this particular patient. And here's an image that shows essentially towards the end of the infusion, so you can see how the structure's been filled. Finally, this is what it looks like on one of our more final post-op images. And you can see, the infusate does not stay entirely in the putamen. These vessels pick up the contrast agent and the vector and transport it out of the structure. In some cases, it might be good if we want to transduce the caudate, for instance, as well, which may be beneficial for these patients. But we reach a stage where there's enough leakage out of the structure, typically, that we don't see the rest of the infusion continue to grow. And that's when we know when we're at a stopping point, along with meeting the criteria for trying to fill a certain volume of the putamen that's set in the clinical trial. All right, so a lot of people involved in the gene therapy work that should be acknowledged, and they're here. So in summary, leave time for questions here. It's important to recognize that movement disorders are a network disease, and I think we'll increasingly be treating them as network diseases, hopefully, as we evolve closed loop DBS. This innovation is going to require a better understanding of normal and pathological physiology. We've squarely entered this era of closed loop DBS. I think it's here to stay, but that's obviously to be determined. And in terms of drug delivery to the brain, real-time MRI guided convection enhanced delivery now very clearly is the key to success, to any hope for success in these types of clinical trials, because we've now demonstrated how much one can learn by following what's happening during the actual infusions, and then using that information for the next patient, and so on, to improve the strategy overall for a given study. Okay, thanks. I'd be happy to take questions.
Okay, thank you, Dr. Richardson, for such an awesome lecture. It was incredible. We have some questions from the audience. Emilia Zambrano asks, if you do a sleep, do you superficialize the anesthesia to do intra-op micro recording?
Aha. No. So when we do a sleep MRI, DBS, we don't do microelectrode recording. There are some groups who I think are doing this or have attempted to do this. It requires getting some long connector cables, because the microelectrode recording equipment has got to be outside the widest Gauss line of the MRI for safety reasons. But that's not something I've done. So our philosophy is that with good imaging in the MRI, you don't need the physiology to put the electrode in the right spot.
Okay. Gibran Tariq asks, great presentation, thank you. Does DBS have any effect on the neurocognitive and psychiatric manifestations of Parkinson's disease?
Yes. Well, That's a loaded question. So there's a lot of published data in this area, but it's somewhat hard to navigate. So there's definitely this finding that happens with subthalamic nucleus DBS from study to study where there's a decrease in verbal fluency. But it's not clear the extent to which that's a motor side effect versus a cognitive side effect. There are definitely patients who, through the process of getting DBS, have an acceleration of their cognitive decline that's happening as part of their Parkinson's disease anyway. And that's also not clear whether, in some cases, it's a result of undergoing general anesthesia or it's related to cortical penetration, or it's related to DBS. But there's definitely that phenomenon that tends to happen in people who maybe are in more of a gray zone in terms of whether they qualify for DBS. And there's some people who are kind of who are teeter on, they're not, they don't have dementia, they're starting to have some cognitive problems. And these can be accelerated by DBS. So it's a little bit tricky. We have tried to understand this in our own cohort of patients and are basically still working on that data.
Great. Sebastian Vasquez asks, good afternoon, Dr. Richardson. What is your personal experience and point of view regarding DBS surgery targeting PPN in order to improve postural instability and freezing of gait symptoms in patients with Parkinson's disease?
Yeah, that's another good question. This comes up periodically at our DBS conference. And I think the issue is that the literature is not clear on this area. And so I don't know. The short answer is I don't know. I think that's probably best attempted in centers who have really active research in that area, who have an expertise. And I don't feel like that's a target that has enough evidence that even that our center, for instance, would do PPN for someone with a specific gait problem because that hasn't been our area of expertise. So I think at this point we would hesitate to do that. But again, that's I'm not an expert in that area.
Okay. Carolina Ferreira asks, great talk. Thanks for sharing your work with us. Do you use or recommend using normative or patient-specific connectomes for DBS programming? In which cases would you use one or the other?
Yeah, that's a great question. Well, I think this is, I do think there's a role for connectomics. And there's a lot of very interesting work being done here. My primary reservation with this is the subjectivity of tractography, which is a basis of connectomics. So I think in terms of personalized connectomics, maybe it depends on how it's done. It depends on how the field evolves. There's still the problem of producing the same connectome in the exact same patient on a different day of the week, and certainly in a different scanner, for instance. So the idea of using, group level connectomic data is very interesting. And I think I do think there's a role for this. And we'll see exactly how that fits in overall. It does seem very clearly to be, at least for the time being, more important for treating psychiatric disease than for movement disorders. And that probably relates to the fact that so far what we know about treating depression, for instance, and OCD, is that those targets are white matter targets, or at least nodes of white matter confluences, whereas we think of our movement disorder targets as gray matter targets. So I think there's an important differentiation there, potentially, in the use of connectomics, because clearly there's a role in using DBS for psychiatric indications, a role for connectomics there.
Fabulous. Mauricio Medina asks, hello, Dr. Richardson. Thanks for an amazing talk. Can you give advice on the main requirements needed to start a human neurosurgery research program?
Aha. Hi, Maurizio. So if we're talking about intraoperative neurophysiology, basic requirements, I think, let's say, we're talking about a neurosurgeon starting a lab, is a partner of some type. I think this is critical. And I had a great clinical partner in Pittsburgh who helped with this, is a neurophysiologist named Donald Cramen. And we recruited a good postdoc, Vitol Lipsky, who became a staff scientist. So a critical component are the people. Of course, the number one component is money. So if you're starting in a new job or moving somewhere, you want to do this work, someone has to give you enough money to hire good people and to buy the recording equipment. I would say probably I'll backtrack and say now the number one thing that is important is an ability to collaborate and reach out and ask for help, because it's really difficult to do invasive human neuroscience work well, I think. It's important to be able to reach out and ask people for help as you're setting up. You have to have an understanding that it takes a lot of time to understand how IRBs work as you start out, and how you handle your approach to the IRB. You have to be willing to take on these increasing emphasis on neuroethics in this work. So you have to really, I think, be willing to put that in your repertoire too. A working understanding of the main issues in neuroethics. And I think importantly, adequate volume, depending on the type of work you want to do, because it's very important in this type of work to be confident about your clinical protocols and clinical skill, and clinical team, which comes with doing cases. And the more comfortable you are there, the safer patient's going to be, but also, the more attention you can spend on doing the neurophysiology work in a way that's, calm and not overly anxious, which is very important when working with awake patients.
Of course. We have another question. David Caldwell asks, Dr. Richardson, thank you very much for an excellent presentation. Do you think that closed-loop DBS will offer significant improvements in clinical benefits, better tremor control, fewer side effects, over open-loop strategies for movement disorders, or is the primary benefit an improvement in battery life?
I think we'll see both. So, I mean, that is one argument that, well, if, the rest of this doesn't work out that well, we can at least figure out how to make the battery last longer, and that would be beneficial. I think there's benefit to that for sure. One thing I forgot to put in this slide is in the epilepsy talk that's coming up, but, movement disorder surgery, DBS, has an underutilization problem. It's estimated that something like 10% of people who would benefit from DBS for Parkinson's disease actually get it. So there's obviously a barrier towards surgery. There are a number of them, but one of them is how the patient interacts with the device. So doing things like improving battery life are important, even if the thing's rechargeable. However, I do think there's a real opportunity, and I would consider it a failure if closed loop DBS did not evolve to reduce symptom side effects. And one thing that we didn't talk about here is that complicates the issue a little bit are now segmented leads, which on the one hand may also do the same thing, but present some engineering problems for how the signal's recorded. So there'll be some really interesting, I think, interplay in the clinical use of these different technologies that are starting to emerge. I didn't even mention directional DBS actually in this talk, which I should have put in.
Okay, and the last question before going for your next lecture, what's your experience with neuro-paced device in movement disorder surgery?
0 in movement disorders. But we have a good experience now in epilepsy that I'll talk about in the epilepsy talk. But I have not used that in movement disorders.
Great. Okay, thank you, Dr. Richardson, for such an awesome lecture. We have now, please, all the audience, keep online on this room. We will continue with the next lecture by Dr. Richardson as well, Modern Epilepsy Evaluation and Advanced Treatment Options. It will start at 4 o'clock.
Thank you.
Thanks to you, sir.